I'm Dr. Makkar from Los Angeles, and I am very pleased and privileged to be with Dr. Jeroen Bax, who is the current president of the European Society of Cardiology. And we have a very interesting topic to talk about. As you know, that transcatheter aortic valve replacement has become a very accepted way of treating aortic stenosis in intermediate and high-risk patients. And there are some data that have been presented on leaflet thickening and subclinical leaflet thrombosis that have created some controversy. So today we are going to talk to Dr. Bax about this finding. Welcome, Jeroen.
Thank you. My pleasure.
So tell us about this finding of subclinical leaflet thrombosis.
Well, I think it started with the fact that CTs after TAVR implantation were routinely done in the past to look for big parts of calcium that would result, actually big parts of calcium in the annulus that would result in paravalvular leakages. But then with the new introduction of newer valves, this actually changed. But in the beginning, a lot of people did CT scans. And on the CT scans, you were one of the first yourself to detect actually this hypo-attenuated leaflet thickening. And you took it also one step further because you looked also at the leaflet motion, and these two phenomena showed that something is going on in some of these valves. Not all of them, but some of these valves.
So how often do you think, Jeroen, have you seen this? Because you were also one of the first groups to be doing CTs. So tell us, how often did you actually find this in your series?
Well, in our series, a bit limited. It's not as large as yours, but we saw in about 10 to 15%, probably 15%, depending a little bit on the exact definition that you use. But I would say between 10 and 15, almost 15%.
Does it depend upon the imaging modality that you use, in fact, when you are looking for this finding?
Absolutely, because a CT scan is a very sensitive method. So actually CT scan detects very subtle findings. And a lot of these subtle findings, this leaflet thickening that we are talking about now, or the restricted motion, a lot of these do not translate into elevated gradients. So what I always speak about is anatomical findings, which is the leaflet thickening and the restricted leaflet motion. And then you have the functional consequences of these anatomical abnormalities, which then result in the gradient. So out of the 10 to 15% patients that show on CT the leaflet thickening or restricted motion, I would say about 5% out of these have elevated gradients, so have a functional problem secondary to these anatomical abnormalities. So in other words, probably the CT scan very sensitive and the echo less sensitive, but maybe more specific.
So what do you think is causing this reduction in this leaflet motion? Are we sure, as you alluded to, that this is actually indeed clot or thrombus?
Initially I was not sure, but I think more recent work that has been coming from the pathology and histological findings confirms that it is thrombosis. So I think that point has been made.
Okay, so is this, I wonder, so is this just an imaging curiosity? Does the practicing clinical physician need to worry about it, or does it have clinical consequences?
Well, that's a hard one to tell, because what we do see is that in these 10 to 15%, the stroke rate is not matching that, because we don't see 10 to 15% strokes. So if you say that there is a thrombosis and then you get a stroke, that's not true. A few percent gets a stroke, but not 15%. But if you think differently, that this is an early stage on the way to valve deterioration, first thrombus formation, then pannus formation, then deterioration, and eventually degeneration, which we see with the surgical valves after 10 to 15 years. Then the question comes if you could influence this process at an early stage.
So that's a very, very interesting hypothesis, whether in a subset of patients, valve durability could be affected by this particular finding. I think that's an important. So tell us, at your institution, how do you deal with this finding? So once you've made a diagnosis, either guided by a clinical situation or incidentally, if you found this, how do you end up managing these patients?
Yeah, so we do at the moment, according to ESC guidelines, that means no anticoagulation, but that in the routine patient. But if we see that the patient is symptomatic in terms that the routine echocardiogram shows increasing gradients, then we anticoagulate them for about 3 months.
Right. And is that using warfarin or NOACs?
Can be both. Can be both.
So I think that's an important point that you're making, that at the current time you could use either one of these agents.
Absolutely.
If there is an elevated gradient and this finding.
And then we follow up with sequential echoes to see if gradient goes down, and that's the way how we treat them. And basically always, if gradient goes up and you treat them intensively, gradient will go down.
So do you think we need to do more research in this area?
For me, the burning question is, we should not treat everybody probably with anticoagulation. We want to, because if you're thinking that 10%, 15% shows this phenomenon, then 85% might not be necessary to expose them to anticoagulation, which comes with a risk, specifically in these higher risk patients or elderly that we're talking about at the moment. So I would say it would be very nice if we could target them specifically, if we could select them. But the first stage that we're going to do now is, let's take the Galileo trial, where we treat all of them or none of them and compare that and look at the outcomes for 1 year treatment of anticoagulation.
Yes. So the Galileo trial is being done in patients that are older, because that's where TAVI is being used currently. But as we talk about, where the risk of bleeding is much high, but as we move forward, we are expecting that this treatment will be used in much younger patients who will basically have, hopefully, much lower risk of bleeding trial. So do you think that the results of the current Galileo trial will be valid when we actually come to very young patients?
No, I think we need to check again then. We need to check again what the results would be in these patients.
Okay, terrific. So Dr. Bax, what I've heard from you is that this is a true finding. It exists about 15% of the times, but there's no need to overreact. I think there is no indication at this time to treat all TAVI patients with anticoagulation, but it is very reasonable to be prudent, to be vigilant, and when you see certain clinical situations such as stroke or elevated gradients, to confirm the presence of this finding and then treat it in those patients where this finding is present, if the bleeding risk allows, with a short course of anticoagulation.
Absolutely. Thank you very much.
Thank you very much, Dr. Bax.